can maintain optimal body mass, changes in lifestyle, body mechanics, use of foot orthosis also, especially support for the medial arch, can be prefabricated or customized. So yung mga doctor shoes na foot orthotic devices, consider also the use of night splints. For physical agents, only laser therapy, and for prevention technique, reduce foot load. Use different kinds of shoes for different things. Um, yeah, iontoporosis is also considered as well as ponophoresis. So that's all for group one.
Thank you so much, Sir Maynard, for that report. We will now proceed to Group 2. May we call on the speaker for Group 2?
Hello everyone, we are the group 2. So this is our patient right here. So we have a 50-year-old female patient that is referred for post-COVID with symptoms of difficulty breathing and cervical tightness and pain. So for our evaluation, so the very first thing we should look at is the posture of the patient. So we have to look at if there is any presence of a forward head or thoracic kyphosis. So with forward head posture, we would look at specifically tight muscles, mainly your SEM, your upper traps, and it could be also um, scalene also. So with this one, if we have any tightness here, we would likely demonstrate any decreased range of motion, especially on the neck motions like your rotation or flexion or extension. So we would check for that. So with this one also, if we have detection of any tightness on those specific muscles, we would also likely detect tightness on adjacent structure, mainly your shoulders. So we could probably detect any decreased range of motion, especially on the shoulder area, since these muscles also are also attached on the shoulder. So it would have some influence on it also. So we would also look at also some thoracic movement, flexion and extension if there's any problem with it or decreased motion. And then after that, we would look at also the lung auscultation. So mainly we've talked about as therapists, we would look at mainly the observation part. Is the patient having problems during inspiration or expiration? So for if the patient has problems for inspiration, so we would likely detect problems mainly on the secondary muscles for inspiration, mainly your what is written here, scalene, levator's cup, upper traps, and the like. So if they're working that hard, so during palpation, you would likely detect some thought band or some trigger points on that area, or you could probably just detect they're a lot more tense or tight because they're working very hard to compensate for the um, inspiration. So you can also look at spirometry. So to really, have a outcome or a specific measure to benchmark on. Then after that, we could also look at the if there's increased chest excursion. So we would also look at also if there's any elevation on the first and the second rib. So possible, sir, can you go down? Okay. So with this one also, we also any conditions, especially if based on the age of the patient, 50-year-old and female. So we would look at also if there any osteoporosis, any COVID pneumonia. We would also look at if what type of pain is it So is it more of a radicular pain, or is the pain more muscularly related? And about other conditions, since this is a 50-year-old female, so and he has chest pain, so likely it could have some um, cardiac problems also. So from what I know or what we've discussed about it, so mostly with your cat with females, there's always a referred pain, especially on the left shoulder. We could probably check for that, or we could refer the patient to tests. So it could be uh, some cardiac test to test if there's really a problem uh, with the patient. So for our management, so the very first thing we should do is, can we go down more? Can you scroll down more? Okay. So we have to first correct the problem with the posture. Can you go up a little bit? Okay, thank you. We have to first correct the posture so that with this one, correct the posture. So we, based on what we have told, so we probably would have some forward head. So you would likely stretch these following muscles that we have stated. And in order for the patient to be more in proper posture, so we could stretch the scalene, traps, levator cup, and most especially your pecs here. So we've suggested different stretches for your pecs. So you have the Y and the W stretch. So it could be in a wall, or it could, if there's a therapist, could probably stretch this one, or you can instruct possibly also as a home instruction wherein the patient could stretch against a wall sa ilang house. So you have also strengthening of the specific muscles, so especially your um, lower traps and your middle traps. So it could be included ang rhomboids to correct the postural problem. And for mobilization, so we could mobilize the first rib and the second rib for this one. And we can also mobilize the thoracic area. Then we could, then afterwards, so we can already teach some proper breathing techniques with this one. So we've talked about focusing on abdominal breathing to correct it. And yes, that's it. Then afterwards, we want to improve the endurance of the patient. So mainly, we're gonna put this patient to a treadmill or a bike in order to improve the cardiorespiratory endurance. And lastly, if this patient, we do not often see this patient, we could suggest some home exercise programs in order to further improve this particular patient. So basically that's it for our group. Hopefully I did not miss anything. Okay, thank you.
Thank you, Sir Chester. Let us now proceed to Group 3. Group 3 reporter.
Hello, good day. Our case is a 12-year-old swimmer who experiences pain to the anterior right shoulder for 4 months. And this occurs as she pulls her hand out of the water during the recovery portion of her stroke. We have three working diagnoses. First is, I'm sorry about the chickens, muscle impingement. Second is presence of tear or a possible tendinopathy. And the third is the female athlete triad. This is a red flag. This is not for us, and this patient will have to be referred to a doctor. And for the assessment part, of course, we do check on the history. We will ask for the patient's work rate, the type, and the frequency of the activity. Basically, we're trying to roll out that this patient is an athlete or I'm sorry, not roll out, but check if this patient is an athlete or a weekend warrior. And for the evaluation, First, this is not in a particular order. The first thing that we see is that we will do a postural assessment and a movement analysis. We will do check for thoracic kyphosis, forward head posture, and a faulty technique during our swimming activity. For the range of motion, we will check for a painful arc at the shoulder. We check for mobility at the scapula and the cervical, thoracic, and lumbar spine. And we will do a visual analog pain scale. This for our baseline assessment. Then next we will do a palpation. We will check for signs of inflammation, joint crepitus, the quality of the movement at the scapula, the thoracic, the lumbar, and the cervical spine. The rationale behind this is that we believe that problems at one region will also cause problems at the other regions. So we're checking globally on the patient. We will do a check for provoking factors, the type of activity that cause the pain, whether this will be an eccentric loading pain or a compressive loading pain. Of course, we'll check for capsular integrity. We'll check for tightness and any restriction of the capsule. We will also do acromion integrity assessment. This is done through X-ray. The reason for this is we were ruling out acromion's structural anomaly. We will do a sits muscle functional assessment. Of course, weakness of this muscle will also result into impingement of the shoulder. We will check for inflammation. The reason for this is to check for the injury stage, whether this is an acute or a chronic injury. And for ocular inspection, of course, again, go back to postural assessment. And also we're checking for signs of inflammation or redness and any form of edema on the region. And for the next, we do ask about the menstrual cycle and the eating habits of the patient. We are doing this because we are trying to determine the possibility of any female athlete triad. So that's this will be a red flag. And the last two, we will do lower extremity and core MMT. The reason for this is that any weakness or loss of strength at this region will lead to overexertion of the shoulder. I will now pass you to Ferdinand, who will give you our management.
Thank you, Sir Erwin. Good day, everyone. So we have a patient who is a female 12-year-old. So in the interest of time, I would be mentioning some pointers that would be quite important in this case. First, she's a 12-year-old female, which means she's not the only one that we will be having our, not the only one who is involved. The parents or the guardians should always be part of her treatment and assessment in this matter. Another consideration would be that she's entering her puberty stage. She might be menstruating. So menstrual period might be affecting her joints, which can cause joint laxity during the menses, which will translate into pain. So because this is already 4 months when we saw the patient or when we see the patient, then we need to consider some compensatory mechanisms happening already during those 4 months. So in the management, and since Sir Erwin mentioned this is global, we check for the posture, particularly from head to toe. The neck, as was mentioned, the neck might be in a forward posture, so we check the scalenes, the SEM, even the thoracic muscles and the chest muscles, and treat appropriately. We also want to correct the posture. Most likely, this is a swimmer, so the tendency would be the pec musculature would be very strong, and it's pulling the child into a kyphotic posture. And mind you, a lot of 12-year-old will be also on their phones, so that might be something that we need to consider. So some postural exercise or thoracic exercises and mobilization. We agreed not to do manipulation on this child, since again, she's 12 years old and she's still growing up quite fast. We also considered managing her core muscles, particularly thinking that if the core is not that strong, her shoulders might be in pain at the moment, because it's the one she's using for power rather than utilizing her core and her lower extremities. So we assess that, and then give particular exercises like diaphragmatic or abdominal exercises. We check also her obliques, abdominal obliques. We check her lumbar musculature. Kasi nga po, it might be that the shoulder and the kyphosis is affecting already the spine all the way down to her lumbar area. So all that need to be addressed, including her hips and pelvis. Again, menstruation might be coming into play, because there might be joint laxity, and if there is something going on the core muscles, she might just be utilizing her shoulders too much. We also would like to strengthen, of course, those core and those lower extremities. Now, regarding the female triad, Dr. Gigi helped us with the female triad by, I think this is about the amenorrhea, bone density problems, and nutritional concerns. Perhaps, again, she might have some psychological concerns with that. So that's the reason why we need to refer this particular athlete patient to a doctor to address female athlete triad. I think that's for our case. Thank you.
Thank you, Sir Araps and Sir Bronner. For our next reporters, please keep your reporting to 5 minutes only. Group 4, you may start now.
All right, so good afternoon, everyone. I'll be reporting for Group 4's case presentation. Okay, so our case is a 15-year-old basketball female player was referred to the clinic due to complaints of bilateral anterior knee pain, worse when playing basketball or when climbing up and down the stairs. So aside from basketball, she also swims, plays soccer, and tennis. Her father is also worried about the way she runs. Now, for the evaluation tools that we discussed, I'll be running over this quickly. Okay, first, we have our entire body postural evaluation, especially with the lower extremities. So we thought to check for, especially for foot pronation and knee valgus. Another is your leg length measurement. Also, we have the virus and valgus stress test to test if pain is caused by muscular or ligamentous. Then we have your patellar grind test to rule out muscular versus bony pathologies. We're also going to be checking for the hip complex symmetry and hypo or hyper mobility. Also, we have to check for the type of shoes the patient typically wears. Check for knee instability. There's patella alta or patella baja. Also, checking for scoliosis, muscular imbalances, and weakness and tightness. So particularly with the hip internal rotators. Also, we have to check for patellar tracking, your VMO strength, and of course, we evaluate for the gait and running. So particularly with forefoot pronation again. Also, we check for functional muscle testing, particularly through stairs and treadmill test. And Next, we check for ankle mobility. Also, checking for muscle tightness, particularly in your hamstrings, quads, and your ITB. And of course, we will be doing your manual muscle testing on your lower extremity muscles. Also, we check for the position of your tibial tubercle alignment. Then we check for symptoms such as your pseudo giving away. We check for inflammation, the bursitis or tendinitis, and checking for single leg balance of your left and right leg. Okay, so in no particular order for the suggested intervention, we have our patellar mobility exercises. Another is your eccentric strengthening of your quads. For general strengthening, we have our stationary bike. And for strengthening of your lower extremity muscles, such as your quads, your glutes, your hip external rotators, particularly for your quads, we suggested, the participant suggested single leg stance on balance board with knees slightly bent, lunges, we have also squats, leg press, most of all exercises, and SLRs. For your GMED, we have side lying leg raise, your clamshells, your fire hydrants, lateral leg raises, and your crab walking. For your GMAX, you have bridging, deadlifts, donkey kicks, split squats, and hip thrusts. Also, we have myofascial release on your tight musculatures. And of course, need not to forget your core muscle strengthening. So that could be an intervention that could be done would be your planking, such as your prone and side planking, your dynamic neuromuscular stabilization exercises, and your quadruped hip extension with knee flexion. So now for your strengthening of hip internal rotators, also for your hamstrings, your gastrocs, and your hip flexors. They also suggested single leg exercises, and of course, not to forget your patient education on pathology and neutral positions. Also, we have, they suggested your orthotics. So that could be shoe inserts, your arch support, your shoe modification, and even knee orthotics to prevent valgus when running and walking down the stairs. And for your modalities, of course, these are just adjunct to exercises such as your ICE method, your ultrasound, NMES, and your laser. And lastly, we have lumbopelvic manipulation, in which research has shown improvement in hip asymmetry in 80% of the cases. Right, so that's it for group 4's case. Thank you.
Thank you for that wonderful presentation, Eureka. And then now let's proceed to group 5.
Hello, good morning. Good afternoon po. I am Josh, presenting for the 5th group. We were assigned a case of a 56-year-old female with pain and paresthesia on the first 3 digits of the left hand. No? So we decided to assess the group in a holistic way, including yung bio, psycho, and social aspects. So we wanted to deliver a holistic intervention. We decided to check for joint instability to rule out if it is a shoulder or a neck condition. So these are some of the special tests that we have decided to apply. In addition to that, we also wanted to rule out whiplash, or if it's an overuse injury, to rule out thoracic outlet syndrome, anterior shoulder dislocation, instability of the glenohumeral joint, and subluxation. Considering the patient's age, osteoarthritis also, we wanted to rule that out. Peripheral nerve testing versus dermatomal testing to assess the origin of the nerve symptoms. We wanted to understand the pain behavior of the patient also, especially if the pain is constant or intermittent, aggravating and relieving factors, to further understand the condition. We decided to we need to check the posture as well of the patient in terms of work, and to understand the work demand. So apparently this patient is required to sign checks as a major part of her job. So that really is a demand for her upper extremity. We have to understand the patient's, the origin of the patient's hypersensitivity, and the consistent paresthesia. So definitely definitely have to understand if it's a physical, psychological, or if it's a work-related or social factor in terms of origin. We also wanted to consider her age, if this condition is influenced by her postmenopausal age, to rule out diabetes in consideration of the possibility of nerve symptoms or nerve conditions. We had to examine her emotional state as well, in terms of sleep quality, sleep position, because this also affects her shoulder. To assess her ergonomic, in terms of ergonomics also, we decided to go for, to assess her workplace, and ROSA, to use a standardized assessment tool, a rapid office strain assessment tool, to see if we can modify or improve the workspace. In terms of treatment, since all these conditions seem to lead to a workplace or a social, or what they call this, work-related condition, workplace modification is our main, in terms of ergonomic changes in the workstation, frequent rest breaks, to consider talking to the management if they can digitize that role or minimize that need for her to keep signing, because if she doesn't change her lifestyle, nothing will change. We considered splinting, but since compression seems to aggravate it more, we decided not to. Heavy on postural exercises and endurance training for her muscles also, including her hands. Manual therapy that will cover or treat her thoracic area, including the first rib, shoulder mobilization and stabilization, soft tissue release. And heavy on patient education as well. The patient was advised to take more vitamin B complex to address that, and also to understand or to encourage the patient to get an EMG NCV test. She's quite apprehensive to get it, so we need to understand why she's apprehensive, but we will push for that. That's it for our group. Thank you.
Thank you, Sir Joshua. Let us now proceed to Group 6.
Okay. Okay, so I'll be presenting our evaluation for case number 6. We have in here a case of a 24-year-old female patient with a chief complaint of lower back pain and numbness, which radiates down to the lateral side of the left leg and left ankle and foot. She reported worsening of pain with activities like putting her shoes on the affected side, lying down in bed, but gets better with standing and walking. Her condition started 1 week ago after lifting a roll-up door at her workplace, and upon entering the clinic, she presented with a lateral shift of her trunk towards the unaffected side, decreased weight bearing, decreased push off, and pushed off on the affected side. Since we are probably tackling about low back pain, we considered multiple differential diagnosis for our patient's condition. First and foremost, if we will consider the patient's age, which is 24 years old, this particular age group has a tendency to do or to have office jobs, which may precipitate other causative factors that may aggravate the already present condition of the patient. Another one, if we will see there, chief complaints of lower back pain and numbness, which may indicate lumbar radiculopathy, spinal stenosis, and even sciatica. So our evaluation for the patient may need to have assessment tools that can determine if there is centralization or peripheralization. As such, we considered sciatica, lumbar radiculopathy, with manifestations of pain, numbness of the left lower extremity, lateral shift of the trunk to contralateral side. And for lumbar radiculopathy, we may want to consider tingling, numbness, and radiculating pain. This may be assessed and evaluated through the centralization or peripheralization phenomenon for low back pain. You may also want to assess for activities of daily livings in the forms of your outcome measures, such as your Oswestry Disability Index and your Beck Depression Index to cover a biomedical and psychosocial aspects of the patient's condition. If we are also to consider non-specific low back pain, it's a type of low back pain that is not attributed to a recognized specific pathology. We may also want to consider muscular spasm due to your lack of muscular endurance. So for our assessment, we will be doing slump test, SLRs, test for lumbar spine and gluteal spaces, instructing the patient to bend over, your Kemp's test, your lumbar quadrants test, your pace maneuver test, and your repeated lumbar extension tests. We will also be checking for manual muscle testing, your dermatomes, your deep tendon reflexes, and of course, your patient education. For our treatment plan, upon delegation for the patient's primary symptoms, if it's a central type of pathology, which is your lumbar stenosis, your lumbar reticulopathy, or a disc problem, we might want to consider first central exercises. But if we are to get a peripheralizing pain, such as your sciatica or your other hip joint problems, then we may focus on that area and provide muscular endurances and strengthening activities for the abdomen and for the whole core. So in short, we might want to proceed with TENS. This is to relieve the pain. Extension exercises such as your prone on elbows, prone on hands. We can also provide the McKenzie diagnosis of therapy or your McKenzie approach. AP glides, myofascial release, nerve flossing, neural mobilization techniques. As for peripheralization of symptoms, we might want to consider thrust manipulation on the lumbar area if we can prove that upon after examination evaluation, we have a sciatic problem that is contributing to the posterior side of the patient, the posterior side of the lower extremity symptoms of the patient, which is the sciatic problem that's contributing to that, and tightness of the lumbar joints that is precipitating the patient's lumbar symptoms. We might also want to consider abdominal activation and trunk motions and breathing patterns. I think that is all. Thank you.
Thank you, Sir Dominic. Let us now proceed to Group 7.
Go, Steph.
Hello, good afternoon. I'm here to report on our case. The 73-year-old male tennis player complained of low back pain radiating to the knee and to the lateral distal side of the femur, and then extends